Good afternoon, everyone. I think we might make a start. My name's Jenny Phillip, and I'm the Chair of Palliative Medicine, the University of Melbourne, St Vincent's Hospital, and also a palliative care clinician at St Vincent's, Peter Mac and Royal Melbourne Hospital. And I'm delighted to welcome you here today to this afternoon session, Cancer and COVID-19 in Victoria. And the session is entitled Unpacking the Complexity of Providing Palliative Care Services During a Pandemic. As I begin, I wish to acknowledge the traditional custodians of the land on which this event is being hosted, the Wurundjeri people of the Kulin Nations, and pay my respects to the elders past and present, and also extend that respect to other Indigenous Australians who may be part of the audience or present online today. So today's event is being brought to you by the COVID-19 Cancer Network. This is a joint initiative brought together by the Victorian Comprehensive Cancer Centre and the Monash Partners Comprehensive Cancer Consortium to assist with the management of cancer care amid this global pandemic. It aims to provide support and advice to clinicians and health services around treating patients with cancer during COVID-19. And it, I guess, hosts a series of professional discussions on digital platforms as we're having today, also providing information and support. And you can join the network via the VCCC or the Monash CCC websites. You can also follow us on social media, us on social media, as you can see here. Today, obviously, we're talking about palliative care and COVID, and we're doing so coming together on what is World Hospice and Palliative Care Day, which is a day that's been set for a long time and a day of unified action to raise awareness and understand needs, medical, social, practical and spiritual, of people living with life-limiting illnesses and their families. And it's an opportunity to raise and talk about issues around palliative care. And we're doing so today in the context of COVID. And COVID has changed almost everything in our lives. It's changed how we socialise, how we shop, how we exercise, what sort of leisure looks like for us, even how we interact with our loved ones. And very dramatically, COVID has changed how we provide and receive care and health care. And nowhere is that more true than in palliative care, which relies upon presence, often upon touch, upon developing a relationship, and upon careful and thoughtful communication. And all of this is different in this year of COVID. So this afternoon, we want to explore some of these differences and their impact. And I welcome you all here to be part of this discussion. The format today will be, we'll have 3 speakers who will each give a short presentation, and then we'll have a panel discussion. As Cynthia had just before, if you have questions for today's presenters or for the panel, you can do this via the Q&A function. And I'd prefer that you use that if you could, or the chat function. I'll be monitoring, so it's easier for me to monitor one. So I'll aim for the Q&A, but I will check on the chat. But please submit your questions throughout the presentation, and we'll aim to answer them during the session as best we can. So today's presenters are, as you can see, some very experienced people. Ms. Danielle Spence, who's the Head of Division Strategy and Support from the Cancer Council of Victoria. Associate Professor Brian Lee, who's the Director of the Parkville Integrated Palliative Care Centre from Peter Mac and Royal Melbourne. And Associate Professor Mark Bowie, Director of Palliative Medicine, St Vincent's Hospital and Deputy Director of Centre for Palliative Care. And then we'll be joined by a panel, Dr. Michelle Gold, who's Director of Palliative Care at Alfred Health, Ms. Gail Wilder, who's the Palliative Care Clinical Nurse Consultant and Manager for Palliative Care Unit at Alfred Health, and Dr. Dan Fleming, who's the Group Manager of Ethics and Formation at St Vincent's Health. So I might begin by inviting Mark to come, and each of the presenters are going to give a short presentation, and then we'll move to the panel. So thank you, Mark.
Thank you, Jenny. I will get myself organised. And great. I just realised I just need to skip back to the beginning. Okay, look, thank you everybody, and thank you for the opportunity to speak today and be part of this presentation and the panel afterwards. One of my other roles is clinical lead for Safer Care Victoria's Palliative Care Clinical Network. So not only at my clinical coalface, but also through to the work within Safer Care Victoria, really seeing firsthand some of the issues and problems that have been seen across the system with regards to how people are not only having care delivered at end of life, but also the ability for people to connect in terms of family, social and other networks with patients at the coalface. I think what's important to understand that in translating what is seen as the Chief Health Officer's directions from the department in the public health unit, that really to translate this across the system in a rapidly changing and rapidly evolving environment can be seen, as many people have seen and many people have let a variety of us know and advocate very strongly for the problems, that there are considerable areas where problems can be found and causing a great deal of distress across the system. As you know, a Chief Health Officer's directives are often seen in a more legalistic term, and therefore are often a blunt instrument in terms of trying to drive policy, drive change, to reconcile what is for individuals and their families very emotional and times of connection. And so therefore we see the same issues arising in many other areas of healthcare where shifts in policy and direction can have a huge impact on the community at large. In terms of Safer Care Victoria's role in very much the clinical engagement arm of trying to make the linkages and advocacy to the Health Services Pandemic Task Force, but also in bringing the advocacy channels back to the community to try and improve implementation of those directions as they evolve and change. If one is to get to the nub of looking at the directions, people may or may not be aware that 3 significant directions are aligned in this particular arena. One is obviously of the hospital visitors direction, which I'll focus a little bit on, care facilities directions and stay-at-home directions. So you can see already that issues will arise because of this convergence of the directions from the Chief Health Officer. And in many ways, the number of times the directions have changed reflects the issues involved in the evolving space of the pandemic, but also indicates that maybe it's taken time for convergence and alignment to occur. Also, in every step of the way, depending on who you are, people affected by the pandemic in terms of the healthcare consumer, family and social networks, or the healthcare providers and their own safety and their own issues and concerns, right through to the locations where that care is being given, there's always going to be this tension and need of clinical context, the ethical context, and of course the legal context. And how that plays out will weigh very differently depending on whether you're a consumer at the coalface, whether you're a healthcare professional providing care, whether you're somebody that's helping to orchestrate and change practice so that we can meet the demands and issues of the pandemic, but also then the person that needs to make sure that we're meeting our legal obligations within a healthcare service, primary care, and across the sector. The nubs of the health directions, just to give an indication of that, if you look at the 9 pages of the health hospital visitors direction, really when we get to about page 6, you look at the definitions that really come down to 2 aspects. In 6.2 is the A to I defines what the exemptions are to the stay-at-home directions for those who can be a visitor to a healthcare service. And in that, it reflects on the people under the age of 18, and then it reflects on the people who are over 18. What's different in the current healthcare directions is that it now, instead of just putting people as a support person, spreads out who these people can be to be parent, partner, carer, guardian, or a support person. And that support person can take on many roles to support a visitor or to support a patient who is actually indeed part of a healthcare service. So again, you can see the complexity and the ability to see that variation is going to evolve fairly quickly if we don't have people that can help enable these processes. And if you're to look at the very terminology of the Health Hospital Visitors Direction in J&K, it defines what may appear quite clear and quite simple sentences as to what happens towards the end of life for people to be supported, but also in the situation, and this is particularly pertinent most probably in the cancer setting, when there's a medical condition that's life-threatening, when it needs an immediacy of patients' families to be present. And again, what you'll notice, and if you've had anything to look at these particular directions, you'll see that there's no particular limitation here to time, but then there may still be situations in health services where limitations have been enacted. There may be timing in the daytime when people are coming to a hospital. So there are things that can shift and change in the way things are then implemented, even though the directions have been made, which are again in this particular document. What's also new in the particular recent release in the last week or so is that the health directions allows for 10 people to congregate outside their home for a terminally ill patient in the community. So that's a new inclusion. Again, just to reflect and just to give you an indication of this particular services that are at play from the Chief Health Officer and the Public Health Unit. Of course, we have policy and planning divisions that, again, across all the areas of healthcare, but particularly involved in this process. And obviously pertinent and relevant are obviously our palliative care and also the cancer services part of the policy and planning divisions within the department. Safer Care Victoria, in taking on that role, is really feeding up and back from the Health Services Pandemic Task Force, and indeed the Clinical Leadership Expert Working Group, which was formed very early on in the first wave of the pandemic, as well as the Centres of Excellence of the clinical networks and the engagement across the continuum of care in all the areas of healthcare, but also in primary and in health and secondary, tertiary care as well as consumers. But what you can see from this slide as well is the complexity then of moving through a health service where the Health Services Pandemic Task Force may be discussing weekly with the Health Services CEO and their Pandemic Task Force, how then that can be moderated, mediated, or shifting as it translates down to the unit level and the clinical staff level of a health service. This could apply to a primary care service as well, or a residential aged care facility. Now, of course, large hospitals have considerable numbers of people and staff that make this process happen, but into the smaller, as we found in the aged care area, that things have changed, and you have smaller health services where maybe the expertise or ability to translate is less formed and able to do so. Just in quickly reflecting as I finish my presentation is to really say that in many ways, I would say around directions 10, so leading to 12, that it was well recognised some of the many issues that were playing out for people that were considered visitors or support people to people that were under the care of health services or in home, community, residential aged care and in hospitals. And in fact, through Safer Care Victoria and really through our networks, we were able to draw the maternal, child health, older persons, palliative care, and as well as mental health and cancer services. Now, in fact, cancer services sit outside the Safer Care Victoria network system and in fact sit within the Department of Health and Human Services. And early on in the pandemic, we were advocating very strongly for this representation to come to Safer Care Victoria, not in changing where their alignment was, but in fact having representation on our clinical leadership expert group. And one of the areas where it's taken time for that to evolve, and we think maybe some of the advocacy that, say, the Cancer Council or has been advocating for has taken time to reach, is the fact that it's only in the last couple of weeks that a representation has been formed on the Clinical Leadership Expert Working Group. There's also in development and implementation guidance for end-of-life care that's ongoing at the moment. And indeed, as I've mentioned, the ongoing work of aligning directions, representation within the Safer Care Victoria Clinical Expert Group, and the evolving development of the metro and regional hubs for healthcare service delivery, including hospitals as well as health services. So I'll just have my timely reminders to stop. So thank you for that. I'll finish my presentation now. Thank you.
Thank you, Mark. Thank you. And I think what you highlighted, all the background of everything you were saying, was that this was something that was changing sort of almost weekly. Some of these policies and things were having to be written very regularly. I'm going to ask Brian to unmute himself and come to present some of the perspectives and the clinical decision making that has been having to be navigated at the coalface in the inpatient unit. Thank you, Brian.
Thanks, Jenny, and good afternoon, everyone. It is very strange giving a talk where you can't see anyone that you're talking to, and yet there's over 100 people listening in. So I hope that this is a useful talk. I'm just trying to work out how do I advance my slides. Okay, hopefully you can see that. So I'd like to start by saying, look, I have looked after many of my patients who have died over the last several months. And I can tell you, as I'm sure you can tell me, that the added trauma of death and dying in this time for both our patients and their families and carers is immeasurably greater than in non-pandemic times. And I think there'll be both immediate and longer term effects on surviving relatives that we will only begin to appreciate now and into the many years into the future. So what keeps me up at night is really thinking about, have we done what we can to provide best care during this time? Have we actually contributed to some of the trauma of this pandemic through the decisions that we've made and the way that we've provided care? The care that we provide is actually provided by people like everywhere else. We do it within buildings, but actually the most important bit of the care we provide is what our staff do, and have we looked after them as best as we can? How resilient are our staff, and what does it feel like working amongst these people? Are they content? Are they happy? Are they scared? Are they worried? And of course, what could we have done differently? And indeed, if we do hit a third wave, what should we do differently? And the context of this is, I'm sure you've all seen these graphs of, the first wave and the second wave, and a lot of the clinical anecdotes that I'm going to tell you happened around the time of the first and second week of July. So in this middle period where things were really escalating and we didn't know how far they were going to get. This is in the context of a hospital plan that really had every ward in a major hospital converting over to looking after COVID patients. This is what this table shows. In a situation that we were very unfamiliar with. This is my team here on a ward round. We're all wearing different clothes. We're all wearing masks and face shields in a very different time. Having our meetings done remotely via Zoom, just like this one, looking at our ward lists and our team and trying to work with each other during what was a stressful and difficult and different period. And in the context of, this news came out on the 1st of October, but this is what we knew was happening in the hospital at the time. At the Royal Melbourne Hospital, which they cunningly split into 2 campuses, we had over 200 people who work in the hospital infected. And if you think that every person infected has probably about 2 to 3 contacts, it meant that hundreds of people were in isolation at the peak of this second wave, which leads to significant effects on who actually is around to provide care. Mirrored across St Vincent's, the Northern Hospital and other hospitals throughout metropolitan Melbourne and some in regional areas too. Just to provide the context. So really at the peak of the second wave, this was the visiting policy at my palliative care service. everyone coming into hospital, and I'm sure lots of people on the discussion today will have come into hospital. Everyone's screened at entry. You have your temperature checked. You have to complete a declaration, and you have to agree to wear a face mask, as we're all getting used to now, and wash your hands and be as COVID safe and distant as possible. Our policy was that we allowed 2 visitors at any time with no time limit on their stay, and they could indeed stay overnight if they wanted to. But we did have a maximum of 2 visitors per 24-hour period. We allowed children, but they should be children that were related to the patient rather than I guess, other children. We applied that policy to all patients admitted to our service. And it wasn't dependent on the phase of the patient, whether they were dying or whether they were admitted for symptom control or for any other reason. And I'm happy to talk about this later, but we decided that this was our set policy and that it wasn't going to be because certain people asked for it or that people asked for an exemption, that this is what we would apply to everyone. And I can talk about that later, because we felt that it was unfair that only the people that the squeaky wheel shouldn't get the oil just because it's squeaky. It should be the same thing for everyone. And that needed to be demonstrably so for everyone admitted to the unit. So we did have some unexpected turns throughout this time. So a patient that I looked after who had been in hospital for 8 days already actually turned up a positive test for COVID-19. This was despite having a test very early on in the admission. And what we know of these tests are that they're pretty sensitive, so they usually don't miss a positive, but maybe that person, and tests that do come back are usually very indicative of infection. So this caught us by surprise, and we weren't looking after this person in a COVID area. So it did have personal repercussions for several in my team as to what they needed to do after this contact unexpectedly with a positive, or the person who returned a positive test. And really it came back down to, where did this person contract this disease from? They were in hospital for usually the time that they would have picked it up. So was that first test a false negative? So was it missed at screening? Did they actually pick it up from a staff member, who we couldn't determine, because no one at the time who had been in contact with that patient had subsequently tested positive? Or had they actually contracted it from a visitor? They had visitors throughout this time period because they were in a very unwell situation, and perhaps that's where this infection had come from. And apart from knowing about where it came from, I guess we had to then work out what the implications to consider were. So did this mean that we had to move to a situation where no visitors should be allowed because of the risks of infection? At that time, the news was 400, 500 new cases every day, and the levels of community transmission were very high. Should we move towards, does it depend on whether the person is in a single room or a shared room? And I'm sorry to say that not everyone gets a single room in hospital, as you'd all know. And the person that did test positive was in a shared room. So does that have implications for how we provide care? And if we were to move to a situation where we'd only have single rooms occupied, the hospital occupancy would have to reduce by about half at a time when hospital resources were stretched. So then, do we think about all staff needing to wear full COVID precaution protective equipment? And at that time, the availability of protective equipment was somewhat limited, and wearing full precautions all of the time is a significant undertaking. So that's just one situation to think about. A second situation popped up where we had a staff member who did test positive to COVID-19, and they had contact with one of our people with advanced cancer just outside of their infectious period, which is deemed to be about 48 hours prior to the onset of symptoms. So this person had a contact with our patient for a sustained period of time at about 54 hours before onset of symptoms. The patient was very unwell, had advanced cancer. A staff member was wearing protective equipment, but not the special mask that we sometimes wear and the full barrier precautions. So what did we do in this situation? And this came at the time of immense stress. So I'm I mean, I can go into what we specifically did, but I really present that to say that this was a situation where we were providing care that was different to what we have ever imagined that we would be doing. In a time where we've never actually been personally threatened by what we do at work. So we're not working in the police department or the army. We've never actually been physically threatened by the work that we do. And that threat was something that we acutely felt that we could also, you know, it was to us, but also potentially something that we could bring home to affect our own families and friends. And certainly we'd experienced that in our colleagues as well. The other thing that was really difficult is there are no guidelines or experience to tell us the best thing to do at any one time. So the people who know me know that I like to say that there's no dummy's guide to how to handle a pandemic that's currently written yet. Unfortunately, I didn't write a lot of stuff down back in 1912 as to how to run a palliative care service in 2020 when it happens again. So we really were trying to make the best decisions that we could at the time. And the balance between staff health and safety with that of our patients and families and carers is precarious. And did we get it right? I'm not sure. We probably had a more liberal and open visiting policy than many other services did, but I know that it did cause trauma and stress for many of our patients and families. And hopefully I've been able to describe how we came to some of the, the decisions and the balance that we had to reach during that time. Thanks very much.
Thank you, Brian. Thank you very much. And thank you for walking us through some of the decision making and some of the, I guess, the rapidly changing context. And as you say, there's no, it's not a well-trodden path where it's clear what you should be doing. So thank you for that. I'd like to now invite Danielle to unmute and I'm not sure, unvideo herself. Not sure what the verb is there, but thank you, Danielle, and perhaps ask you to speak to some of the experiences that you've been hearing about at the Cancer Council.
Thanks, Jenny. And I'm here representing Cancer Council, but I can also say that the advocacy that Cancer Council's been doing around issues for people in palliative care at this time is very collaborative with other patient groups. So we've been working closely with Breast Cancer Network Australia, with Canteen, with PanCare, Lung Cancer Foundation, Prostate Cancer Foundation to really share some of the challenges that we're hearing through our information and support lines. And what I can say is that as patient support organisations, we've really been inundated by the number of queries that we're getting from the community who are confused around the interpretation of some of the guidelines around visitors and are really uncertain as to how they can best support people who are experiencing in their family who are coming to end of life. So I really want to talk about some of those issues today, but am also very conscious of the challenges for health professionals. So we're here to represent the patient voice, but I'm really mindful of Mark and Brian and all of the effort that individual clinicians are putting into this time. One of the things that's probably the loudest voice that we hear is just the inconsistency of the interpretation of the guidelines. It's been terrific to see the most recent hospital visitor guidelines really addressing some of the challenges of palliative care, and hopefully some of our advocacy efforts are making a difference. But what we still know is that people having different experiences, the people who have the least health literacy are really feeling the most challenged. So whilst it's great to see the new guidelines, for example, indicating that someone could be outdoors with 10 people gathering at this time towards end of life, that does need sign off by the Chief Health Officer or the Deputy Chief Health Officer. And not everyone is empowered to know how to action something like that. And what we hear regularly from the calls to 13, 11, 20, and we're fielding about 200 or so calls, or 180, I think, on average since the COVID pandemic began. Many of those calls relate to frustration, and the amount of frustration, I think, is getting louder as we see the incidence of COVID in our community declining, especially in regional areas. Even today, we saw media around an example of a family who were frustrated by their experience in a regional hospital where there is no COVID cases that we know of, spending time with a dying dad, but not being able to bring their baby in with them. So a son tag teaming with his wife, and then actually missing out on those last vital moments with his dad because he stepped out with the baby at the time that death was imminent. And then the frustration of that family being allowed to gather together after death with their dad's body, being able to have more people in the room, and the frustration of where's the common sense? Why couldn't we have this experience while dad was dying? Why are we having this experience after? So I think people are questioning where that compassion is consistent. And that's not saying that there isn't compassion amongst our health professionals, but the experience that people have really sometimes does depend on who they get to speak to over the phone. And what we've really been advocating for is a central way that people can have conversations about concerns, community organisations of fielding those concerns, but we need it's just a phone number on a hospital website, and that's not enough, especially for people with low health literacy. We've certainly been concerned for some of our communities who don't have English as a first language. We know that there have been concerns for our Aboriginal and Torres Strait Islander communities, and it's good to see kinship mentioned in the most recent guidelines as an exclusion that needs to be considered. So all of this is complex, but there does seem to be some blanket rules that are causing great frustration. Canteen, for example, are really advocating hard that blanket bans on children need to be lifted. And whilst the most recent visitor guidelines do talk about children, grandchildren, siblings being able to be with someone at end of life, the example that we saw in the Regional Health Service today shows that that's not always implemented as a policy. So Canteen have been fielding some really complex calls of distress, sometimes from adolescent children who've been a main carer for a mum or a dad. And for some families, we also know that it's meant reluctance to go to hospital. And so families are struggling longer at home, putting off coming into hospital. And often they know that that's going to be via emergency. It might be directed to COVID wards until there's tests can come back as being negative, and people don't want to waste that time. We also know that community palliative care is really stretched at this time. And even though there might be nurses who are able to visit people at home, the regular community support that people have isn't there. And so the tension of, do I care for someone at home? If they're in hospital and the option is to come home, families don't always know how they're going to manage. They don't know how they're going to cope. And they're calling Cancer Council and other patient advocacy groups for assistance. And I think the concerns around everything from fines to unsure of the rules, 5-kilometre distances, all of the complexities of which we're living are really adding to the distress that we're hearing from families. So some of the advocacy calls that Cancer Council and our collaborative bodies in our other patient groups are really calling for is how can we have more consistency of the interpretation of the visitor rules so everybody knows where they stand. And of course that might be different because different health services might be experiencing different risks, but can we start to open up in some of the centres around the state where those risks are lower? Can rural people spend more time together with people who are dying in hospital? So they're the sorts of challenges that we're really hearing from. And we are encouraging all of the people that call our helplines to go back and speak to their clinicians. But as I said earlier, the frustration does seem to be getting louder. And I think that as we start to open up, hopefully in the next few weeks as a community, what does that mean to helping support people spend more time together with the people that they love who are dying? We know from other states that there are still many restrictions, even though health services aren't facing the same types of risks as we are here in Victoria. So we have real concerns that this isn't going to be a quick fix, And I think we all need to come together as people who are really committed to supporting patients at end of life to make it easier for people. And thanks, Jenny. Actually, Jenny, before I finish, I did want to just end up with a quote that I haven't had a presentation because I really wanted to speak to the emotive issues rather than to a presentation, but I will read out this quote. Mum was a victim. She was a victim of COVID. Even though she didn't have the virus, she was a victim of it. She won't be counted in the statistics because she didn't have the virus, but she was the victim of what this virus does to people who have a terminal illness. Thank you.
Thanks, Danielle. Thank you very much for bringing that voice and bringing it so clearly. I would like to invite now the panel to unvideo themselves. I still haven't got that verb right, but perhaps I might ask the panel to stay on mute unless they're actually speaking. That would be good. So welcome back. So stay online, Danielle. Welcome back, Mark, Brian, and welcome Gail, Dan, and Michelle. If I could invite you all to put on your video. Thank you, and Brian, thank you. So I'm going to open with a few questions, and then there are some questions that are trickling through into the Q&A room, and I would invite you to continue to submit those. But perhaps I might open up, if I may, Michelle, with you, to perhaps if you could comment on your reflections on how COVID has changed how you deliver palliative care or your focus within palliative care.
I wasn't muted and then I was. So thank you, and then thanks to everyone who's put in the questions. I mean, I think it's so profound. It changed really everything that we were doing from, as Brian was saying, how we set up our ward rounds, how we could interact with people and how we could bring them back to clinic. Sorry, I'm about to have an interruption. But I think one of the really difficult things was in palliative care, we are very good and always very mindful of focusing on a person as in their context with their family and advocating very strongly for that person. And all of a sudden, when we were on the ward and wanting to advocate for people to have visitors or extra visitors or longer time visitors, we had to suddenly be mindful of what effect that might have on other vulnerable people in the same ward. So if we've got a haematology ward with 25 or 30 extremely immune compromised patients, we were suddenly having to think about them as being potentially harmed by the things we were doing. So look, we worked really hard. We talked to all of our staff members. We certainly liaised very closely with the teams, but it was a lot of additional, I guess, a lot of additional things to consider and work on. So it certainly was a very major change. And I think we were also being suddenly called upon to be active in all kinds of different places and different areas. So providing advice and care outside of our usual structures. Again, as people mentioned, there was a lot of fear about coming to hospital, and we were suddenly trying to give advice over the phone in ways that we may not have done before.
Thanks, Michelle. So Dan, I wonder if sort of taking up that point of thinking about the person in front of you and then thinking about those other, or holding all those other things. I have heard you talk about this notion of competing goods. I wonder if you'd be happy to talk about that a little.
Thanks, Jenny, and thanks everyone for such rich contributions and discussion so far, and everyone who's joined too. Yeah, what a time to think through the ethical gravity of the work that you all do day to day, and that many of the people online receive or have family members who receive. The work that tries to uphold the dignity of the people in front of you and their families in a really comprehensive way. And what a time too to reflect on all the big ethical questions that are right at the heart of our healthcare environment, that it's quite incredible that they've gone unnoticed for a lot of time during when times are good, but now we find ourselves in a crisis, and some of the gaps or blind spots, I suppose, pop up really, really clearly. often when we think about ethical issues, we're thinking about the ethics of discrete actions. So should I do this or not? Is this action aligned with an ethical standard, or is it against an ethical standard, and so on. But there are different kinds of ethical questions that I think have become much more prevalent in healthcare, but also in our community more broadly during the pandemic. And if I can just use an example from a different context, it might help to set the scene a little bit. If you imagine a lot of the people we've heard from today are amazing professionals in what they did. Now, they didn't just turn up professionals, they've studied for a long time. So they've pursued the good of becoming a practitioner in end-of-life care, or leading a great organization like Danielle does, which attempts to support the better care of patients around the community. In pursuing that pathway, they would have sacrificed time with family and friends at certain moments, another good. Both of these things are good. It's not that one of them is good and the other is not. They're both good. And in the course of our lives, we often come across a situation where we need to prioritize one over another. And I think what we've been exploring today is exactly the case of that. To come to your question, Jenny, is controlling infection is a good thing. There's no question about it, especially with a disease as horrible as this one. But so too, as you all well know, in the context of end-of-life care, is the kinds of things Jenny introduced us to right at the beginning, the proximity of other people, being wrapped around by family, and the heartbreaking story that you shared, Danielle, of a son who couldn't be with his dying father right at the end of their life. That proximity is a good as well. And I think the real challenge in this context has been that we've been doggedly committed to one good, sometimes at the expense of the other. And in contexts like this, the tool that we use in ethics is there's a combination of different tools, but one of them is related to proportionality. So thinking proportionally about the goods that we're trying to pursue, and in what context we might put one good ahead of the others, even when it contains risks. And this is the other important point, I think, and this comes to some of the observations that Brian was making earlier. Often pursuing a good does have some unintended, difficult, risky side effects. We don't notice that. We can see how blessed we've been for so long that we haven't had to think about this that much. But now we do have to think about this and think about the risks we're willing to take on to protect an important good like people being close to one another. So Jenny, I hope that gives a bit of an overview of some of the tools that we use in an ethics consult to think about this. The final thing, just to note that a lot of people have rightly lamented a lack of consistency. And I think that one of the issues we probably all need to grapple with is where we're looking for the consistency. I think we can be very good in terms of having consistency of principles and guidelines, but the more we descend into detail, the more things are going to be different because we're grappling with different kind of circumstances which give us a different playing field, if you like. And our community doesn't seem to have a lot of tolerance for that, nor do our healthcare environment. We love procedures, we love checklists, we love guidelines, but boy, hasn't this shown us that those things fall apart when we try to become too prescriptive. And that seems to me to be in some of the comments that we've heard today. Thanks, Jenny.
Thank you, Dan. Thank you. I wanted to just bring Gail into the conversation, and then I might go to some of the questions on the Q&A. Gail, one of the things that is apparent throughout all the discussions is that we are not providing care in the way that we wish we were, and people are not receiving care in the way that they wish they were. And I'm wondering, as if we just take a moment to reflect as on World Hospice Day, what sort of the impact of that do you think on the health providers, like the palliative care health providers, and how do you support them in that sort of instance?
Thanks, Jenny. It certainly has been challenging times for all of us. I think talking from a palliative care perspective and nursing perspective around the Alfred, We've seen a lot of moral distress all over the organisation, and in this case it's really around the visitation restrictions within COVID-19. I mean, the nurses and other health professionals around the organisation have found themselves in a situation where they know that the restrictions are there in place to protect the greater community, the patients in the hospital and our staff, but at the same time they're feeling the distress of patients and families not being able to see each other in these trying times. And, you know, particularly for the terminal patient, it's very, very difficult for them and their families. I guess as a team, we've supported nurses and other health professionals around the organisation, supported them to advocate for patients and families, tried to work around the visitation restrictions that we've had. We've developed a letter for families to have that would help them get through roadblocks, perhaps to be able to visit dying relatives at home, to try and navigate the security at the front doors of the organisation to be able to come in. It's been really, really hard for everybody. We have, and nurses around the organisation have been down to the security desk to escort patients' family members up to the wards in order to be able to see them in their last moments. We've advocated for children to be able to come into the organisation and see a dying relative, which is heartbreaking to watch. And I guess the other thing that we do is we found that we're doing a lot more debriefing sessions around the organisation. Our grief counsellor has been very involved in supporting nursing teams on the wards and enabling them to be able to talk through their stress at this time. So, yeah.
Thanks, Gail. And I think it's interesting, isn't it? So the ways of supporting staff and the ways of supporting patients is in the detail, as you say. You know, the letter, the really sort of the tangible, detailed things are the sort of, you know, those creative, not workarounds, but, you know, work withins, I guess. Thank you. So there's been some comments in chat, and I might just read out a couple of points. One point that's been made was how fraught, even in non-COVID times, having oncology care and coming to the hospital and coming to Peter Mac is for someone receiving cancer care. And then coming again last Friday, the same day that they were there a few months previously. And it does feel like we're living in a wartime situation. Everyone's wrapped up in their bubble of anxiety, concern. Pre-COVID, there'd always be someone in the environment, people around, people would be upbeat with positive vibes, and that even the sort of the environment is different. There was another comment that different organisations, one of the differences in how policies might be realised on the ground relates perhaps to different organisations having different resources and capabilities and environments and indeed patient cohorts, and that can be a source of great frustration to those people who are on the receipt of care. And I just wanted to bring up, perhaps Mark, I might throw to you, because it's a very pragmatic question around that someone was unaware of the outdoor group support being available to patients at end of life. How is the public being advised of this? Do you have any sense of that, or do you know if that's...
Look, all I know is I actually listened to Daniel Andrews when he spoke, and he actually spoke to that point in his presentation at the time of when they were announcing the changes on the Sunday broadcast that he was making. But again, I'm not sure where that publicity has gone from there. So I can't directly speak to that. But I agree, that is a problem, trying to keep people abreast. And this is one of the issues in healthcare services. I've been supporting a few directors of services, not just palliative care, but oncology and others, where if their engagement within their organisation isn't robust and they don't sort of have agile processes of information dissemination, then the key people that should understand these things don't necessarily understand them. And so therefore, when the queries and questions come to them as heads of units, directors and so forth, they don't necessarily understand what's even happening within their own organisation to be able to give the right advice to patients and families at the same time. So in some organisations there's these disconnects, and others people are very connected and quite agile in the way that they can deal with these queries and questions. Yeah.
Thanks, Mark. Brian, I wonder if we've been talking largely about palliative care and hospitals. Do you feel comfortable commenting a little bit on about the community provision of care?
Thanks, Jenny. That's a question without notice. I think community care has been very difficult and complicated during this time as well. I predominantly work in the hospital, but I do work in the community as well. The hospital has, as you mentioned before, it does feel like a war-like environment. We have people guarding the entrances, we scan everyone coming through, you have to complete a declaration, and it's very different when you're walking into someone's home. There's that degree of security from a healthcare worker perspective is very different. I know that a lot of people have sought to, several of my patients have decided to go home, like where they have a large family of 10, 12 people not able to visit concurrently, they have chosen to go home, and the ability to provide community care has been different. So the council worker that assists with the shower, the person that delivers the hospital bed, all of those things have been different. The nurse that visits to change the medication delivery device, everything has been different and much more complicated and a lot more difficult than it would be in a non-pandemic time. People have done it under amazing circumstances, and to a certain extent it's happened because it's really been a desire from the patient, supported by their family and supported by us as best as possible in a difficult time. I know that some community services have been very busy over this time and delivering care in different ways as well, video, telehealth, phone, etc. And some services have paradoxically been quiet as well because of restrictions. So there's no universal experience. The experience across Melbourne has been very different too. The outbreak has not been uniform across Melbourne. It's been largely in pockets of the severe waves, and the way it's been responded to in different parts has been different.
Thank you, Brian, and sorry about the without notice. Just a comment from Anna Kennedy in the audience. From an allied health perspective, we found it particularly challenging when facilitating end-of-life care discharges to the community, when previously we'd facilitate carer training on the ward to empower patients and families in feeling confident and capable of this transition. So it's sort of another layer, I guess. I wanted to ask Danielle, would you mind commenting on what role you feel the Cancer Council has sort of played during this pandemic? Clearly it's been a conduit for some of the community distress.
I think it's about, Jenny, bringing to the attention of policymakers and health services the challenges. And the worst situation is when someone's been turned away by the security guard at the door. I think listening to Gail talking about the nurses coming down and meeting people and providing people letters to be able to cross more than 5 kilometres. These are small things that really make a difference to patients. And how do we get that to be consistent? So we don't hear this distress and frustration of people who, if it was any of us, we'd know the right people to call and we'd be able to cut through. But not everybody has those connections or that health literacy, as I spoke about. So I think we need something consistent. And someone in the audience asked about, how do we make it more common knowledge that there are things that people can do. They can have gatherings with 10 people. Where do we find this information? It's really I think up to all of the key clinicians on this call to help be aware of what the rules are and support people as best they can, because people are navigating it and that everyone's navigating challenging times at the moment, but trying to navigate complex health information. You know, when you're homeschooling, you're looking after elderly people, you're trying to change the sheets on someone that you're caring for at home. You don't have all those community supports, as Brian said. So we need to empower people and give them the right information as consistently as we can.
It's Mark here. Can I just add, Jenny, sorry to, that there is certainly considerable work going on at the moment following the last iteration of the directions, and cancer services, palliative care within the department are certainly working on, with Safer Care Victoria, to have exactly what you're talking about, some sort of translatable, understandable guidance around implementation. So that's a key bit of work that's going on at the moment.
Great, thanks, Mark. Michelle, Kath Ludbrook has said we need to be equipped and advocate for funding to support those many people with complicated or prolonged grief responses moving forward. Do you have a comment on that?
Yeah, she's completely right, and I really feel that this is going to be something, we're already seeing it. We're hearing very much in our feedback from families just in a very few short months that this is a significantly increased problem. I don't know how we get that increased funding. I do know that peak bodies like the Centre for Grief and Bereavement and other organisations linked to that are very well aware that families and individuals are going to need increased support, and they're trying to learn as much as they can about how to provide that support in an accessible, cost-effective way on alternative platforms if we can't have face-to-face meetings. There's a lot of work going on by the practitioners themselves and their organisations. I can't personally speak to how and where that will be funded. I suppose we've had a little glimmer of hope in the extension of the funding for 20 psychology sessions now from 10. So there are maybe avenues along those lines, but yeah, look, I think that's going to be really, really important. And you know, you look at the Northern Hemisphere and this isn't going away in 6 months. We've probably got a brief period of respite and we may well be doing it all over again next winter.
Yeah, thank you.
Can I just add to that as well? And I think we need to bring the consumer voice into some of the post-planning. You know, we've got this window of low community transmission. How do we also converse with the people who've had these experiences to see what it is that's going to help those families, because it is going to fall also back on community support organisations, Cancer Council and the other patient groups. So we can bring forward that patient voice. So I think, Mark, as you're starting to think about some of pandemic directions.
And absolutely, I can concur. The consumer group within Safe Care Victoria is extremely active and indeed increasing in its numbers, including the Commissioner for Senior Victorians and other sort of key people that can advocate in a much stronger and more proactive way.
Right.
Yeah. I want to, we're getting close to time, and I think maybe this is an interesting question for people on the panel. Is what advice, Dan, this is very out of a bit of perhaps an unfair sort of throwing the ball to you, but I'm just wondering what maybe advice would you give? So what's been sustaining people in the leadership roles, given the pressure of their respective organisations and the pressures of care and supporting families? Do you have any, that's a very unfair question to throw to you, but I wonder, it's a good question. I wonder if you've got any thoughts of how you would talk to your colleagues about this.
It's a beautiful question, Jenny, and it's a hard question. And yeah, the pressure the whole community has been under is extraordinary. The pressures leaders have been under, especially extraordinary. One of the things that our leaders at St Vincent's have been doing, which I think is worthwhile for all leaders to consider, is why you got into this game in the first place. And there'll be a story, there'll be a moment of encounter, there'll be something that's right there deep in your heart that got you into this. And in an ethical framework, probably what that story teaches you is the goal that you're seeking after in this work, that you've always wanted to seek after in this work. And I think the sustainability piece for leaders is remembering that that goal is significant in difficult times and in good times. And when the difficult times come, we don't change what our goals are. In fact, that's when we should be committing to them, as the overused phrase goes now more than ever, to show that they're really worthwhile even in difficult times. But it is more difficult, and the good work I've seen have been related to a lot of debriefing sessions. Gail was mentioning that before, but also beautiful peer support among colleagues who really are taking the time to look out for one another. And healthcare hasn't always been good at that. And that's another big learning in this space, I think, that we only provide service as good as the support that we provide for one another as well.
Thank you, Dan. That's a great way to sort of sum up. I guess that brings us to the end of today's COVID and cancer webinar. And thank you to everyone for tuning in. Barack Obama uses the term of people of good hearts, which I think he means that people who come with a willingness to speak and to hear, and above all to listen. And I think this afternoon we've had people of good hearts in the panel, our presenters, and with our audience to come and to share and to listen. So I wish to thank our speakers, Mark, Brian, Danielle, Dan, Michelle and Gail, and also you, the audience, because of your good hearts. And I want to draw this session to a conclusion, but I am mindful that there is a lot of distress, and it has and continues to be a stressful and difficult time. And we do have people who can offer support, and I would really encourage you to contact the Cancer Council Victoria Cancer Information and Support Line, which is 131120. Also, if you are a health professional and you wish to join the network, then you can do so on those websites. So the next Cancer and COVID event will take place on Wednesday, the 21st of October. And this is a discussion around delayed cancer diagnosis and the impact on primary care. So once again, everyone, thank you for coming, and thank you for sharing and for being open and good-hearted. Okay, bye-bye.
Thanks, Jenny.